Hi, my name's Paul Garcia. I'm a neurologist at the UCSF Epilepsy Center. Um, I would like to talk today about epilepsy mapping in the operating room. And I know that this is kind of a super niche subspecialty kind of area to think about, especially for folks that are maybe sometime going to be thinking about epilepsy surgery for themselves or for a family member. But I think it brings up a lot of issues that people might be interested in, whether or not they're interested in epilepsy surgery. I realize this is very much a specialty topic and that questions could pop up while we're going through. There's just a few of us here. And so I really welcome you to interrupt and ask your question. If there's something that I haven't made very clear, it's very, very likely that everybody else is wondering pretty much the same thing. So feel free to stop me. If we don't get through all the slides, that's still okay. It'll be something that I'm happy to make sure that we cover what we can. And also, please just remember that I'm not so used to using Zoom for presentations. I realize that chat is like one of the ways that lots of people get their information to the presenter, but I'm not 100% sure that I'm going to see that as we're going through. So feel free to just interrupt with your voice, and that will be good because then that will catch my attention. So epilepsy mapping in the operating room might sound like a newfangled thing or something that's like brand new, something that is on the cutting edge of epilepsy surgery. But in fact, epilepsy mapping in the operating room, figuring out how things are going right there in front of your eyes if you're the surgeon while you're trying to figure out how to do the best operation, is how it actually all began. This is a picture from the Montreal Neurological Institute where Wilder Penfield, one of the very first surgeons to become interested in doing epilepsy surgeries, was doing an operation on this person who's here. You can sort of see they're looking out from underneath the drape with the anesthesiologist in front looking right at them and helping them get through the operation while the surgeons are over the top. And you can see the EEGers, usually the neurology nerds like myself or whatever, are actually in the back looking at the EEG coming out the other side. I mentioned Wilder Penfield. This book by Wilder Penfield, Epilepsy and the Functional Anatomy of the Human Brain, actually describes the very, very early days of mapping in the operating room, where the surgeon and the epileptologist are looking at the brain with electrodes on top of the brain, recording the EEG, and trying to figure out all that's going on in front of them. It also describes basically ongoing experiments to figure out how the brain is organized, where the brain is electrically stimulated at places, and what happens when the brain is electrically stimulated at this place compared to that place, and how that helps us to form a map of the brain and to understand how to do the operation. So what are we actually doing in the operating room? Well, as Yogi Berra said, you can observe a lot just by watching. That's kind of what we do. We just go in there and look. I guess the best way I can describe it is when we're doing brain mapping in the operating room, we're kind of doing exploratory surgery because you're using the results of the mapping as it's taking place to help guide the operation. And how does it guide an epilepsy surgery where we're trying to remove the tissue that's causing the seizures so that the person can gain seizure control? Well, you basically just place the electrodes on top of the brain, record from them, see the area that looks the most irritable, the most like kind of tissue that makes seizures, and see if you can distinguish that from the places that are important for the person. And we find the important places by electrically stimulating the brain and seeing what happens when the brain is electrically stimulated in that place. So this brain mapping in the operating room, we consider as an adjunct. And I want to put in capital letters there, not a replacement to the chronic EEG recordings that we get outside of the operating room, especially the ones where the surgical planning is made with using grids of electrodes and depth electrodes inserted into the brain. Now, on those situations, you often need days of recording so that you can record seizures, and it's important to get the very, very most exacting, precise information that you can possibly get. So we're not saying that the recording just during the time when we're in the operating room completely replaces that as a way of figuring out where the seizures are coming from. However, it can be helpful in supplementing them. In other words, I think of it as kind of fine-tuning. It's a way of looking at the last minute to make sure you've got it exactly right. So it can almost always serve as an important adjunct, an important fine-tuning of the operation. Another thing that can happen, and I want to sort of say that this is just for some cases, is that the operating room mapping can serve as an alternative to recording with those grids and depth electrodes in place. Now, it can't do that for all cases, not even close, not even most cases, but there are some cases, especially cases where it's a certain kind of lesion causing the epilepsy, like a kind of lesion that we know is highly associated with causing seizures, so that we already have a head start in understanding where the seizures are coming from. And in that kind of circumstance, we can rely on that information and then just fine-tune it in the operating room and not even have to go through days or weeks of recording with electrodes inside the person's skull and head. Finally, there's one other situation where brain mapping in the operating room can be very helpful, and that's in people who may not even have epilepsy at all, or may have very well controlled epilepsy. And then that's in people where they need to have an operation to have the cause of the epilepsy removed, say for a brain tumor, or for a special kind of blood vessel malformation that would be at risk of rupturing. And so what we would use the brain mapping for in that situation is to figure out about how aggressive we could be in the operation without hurting the person. In other words, what if it's near their language area? We need to be able to define exactly all the places in their brain that are important for language so that they can have the operation done in the safest way, where the very most of the brain tumor can possibly be removed with the least risk of causing them a problem. So what are the advantages of mapping in the operating room compared to getting all the information that you need from recording up on the monitoring unit for days and weeks on end with electrodes inside the brain? Okay, well, one advantage is that it doesn't cost as much. and it's less likely to hurt the person because you don't have to keep electrodes on or in the brain for a long period of time. So less risk and less cost. Another advantage of it is that you can move the electrodes that you're recording from around. If you don't like where they are, say you're recording from areas that are around where the seizures are coming from, but you can't quite see it right. While in the operating room, you just say, oh, okay, let's shift everything over a little bit to the right, or let's spread them out a little bit more to figure it out, and then we can, refine it. Unfortunately, once you put the electrodes in, and when you're going to be recording for a more long-term session, you can't move them. They're stuck. They're in one place. Then if you do want to make an adjustment, you have to have the person go back all the way to the operating room, open the skull back up and move things around, and then hope that you put them into the right place. Well, there can't be only advantages. If there are only advantages, that would be the only thing we'd ever do, is to just record EEG in the operating room. But that's not what we do. And the reason is that there's some disadvantages to figuring things out on the fly in the operating room. One of them is that you have a short recording time. So it's less likely that you'll actually record seizures. In fact, it's probably more likely than not that you won't record seizures while you're in the operating room. And that means that you're making the decision based on the electrical irritability and discharges that are just there all the time. You don't actually see how the discharges change when the person's having one of their usual seizures. Another disadvantage of having less time is that when you're trying to sort out, well, what do we do in the situation? Now we have the information. What do we do? You have less time to make the decision. And part of that less time to make the decision is that obviously one of the people that can't be so involved in the decision is the patient. So if you're at a situation where you're sort of trying to decide, well, here we are up at the edge of where we would do the operation, and you sort of find out there'd be a little bit of risk, you could have a little bit of risk to, say, the movement of your dominant hand, which is really important to you. How much risk are you willing to accept? That's the kind of thing where, well, we can't make a very good long-term kind of decision there. You kind of have to know ahead of time how you're going to base your decisions. You can't wake the person up or even talk to them usually while on the fly, even if they're awake. You don't want to do that because that's kind of a harsh way of deciding about something so important to a person. So we have that as definite disadvantage. You have to kind of decide ahead of time how aggressive you would want to be in a certain circumstance. Finally, it requires a really experienced team. It is kind of hard to do. It requires a team that understands how to put all the electrodes on. From the technologist standpoint, the nurses have to have everything right in order. Surgeon has to know exactly how it's going to go. Anesthesiologist is really important, and I'll give you an example about that. So what is this? I just kind of wanted to show you what it looks like when we're in the operating room doing mapping. One way you can do it, and because you can do it a lot of different ways, is you have to put electrodes down on top of the brain that you record the EEG from. And this thing that looks like it got it from outer space is called a crown of electrodes. And it's called a crown because it's anchored by this post right here into the skull. And then these little wire electrodes are placed down so that this tip just sits on top of the brain, nice and softly. This little wire here at the top, you see that's flexible so that it can ride on top of the brain and it won't puncture the brain or something. It just sits on top nice and softly. And that allows us to record EEG from the brain. This is another type of crown, and it's just the exact same idea. You can sort of see these little flexible wires placed on top of the brain to record the EEG. This is kind of a different strategy, a grid of electrodes, which is a bunch of little metal electrodes with wires coming out the end, embedded into a flexible plastic sheet that can be placed on the brain. And the advantage is that this gets all the electrodes down really quickly, makes it super easy to place the electrodes down. The disadvantage is that then that kind of blocks out electrical stimulation. So you have to stimulate through these actual electrodes. You can't just like use a little stimulator and stimulate anywhere in between here because there's plastic here in between. The other disadvantage is that they're all kind of locked into place. So you can move them to get them to where you want to be, but if you move one, you move all of them. So you don't have quite as much flexibility. So what is it about mapping in the operating room that's so doggone hard? Let me just tell about one kind of thing, the anesthesia that we use during the operating room, during the operation. This is a depthogram that shows what would happen in an awake mapping case where we're mapping somebody's language function along with recording their EEG to figure out where seizures are coming from. So we're going to figure out where their language is. We're going to figure out where their seizures are coming from. We're going to use that information to preserve their language and remove their seizures. But this just shows the ups and downs of the anesthesia that's needed during that time. Because when the person comes into the operating room, you're here for positioning, and then they start the drilling through the skull, and you want the anesthesia way up here during the drilling, not because it hurts, because the local anesthesia takes care of that. But everything I've ever been told by anyone who goes through one of these operations, hearing the saw going through the skull is absolutely mind-bending and super loud, and nobody likes it. And so you want the person to be out during the time when the sawing is going on. And then, of course, you can't be totally gonked out when they're testing your speech function and language function. So here you go. You have to like bring the anesthesia level way down for that, for the mapping. So the person still gets a little bit. You want to have the edge taken off of it so that you're relaxed, not anxious. But it has to be way down here. And then during the operation, it goes way up here. And sometimes if you do more mapping, then you have to bring it back down, and then you can bring it back up there to the point where even it stays, the person is still kind of out of it when they're taken to the recovery room. Well, what's another thing that anesthesia can do that makes it really hard? Does anybody see what this is a picture of? I'll just spoil it and say, this is actually like I think a lion in here. And the reason it's so hard to see, oops, I see something here. Yeah, yes, agree. It is a lion. But the reason it's so hard to see is that the surroundings look almost exactly like it. So it blends in completely. And what's the point about anesthesia in that? Well, here's the point. Oops. This is what the EEG looks like when you use sevoflurane. So here's propofol, one anesthetic that we use that doesn't have too much effect on the EEG. It has a little bit of effect, but the sevoflurane makes it look like this. Just ratchety up and down, high frequency, sharp activity. And I want you to remember what this lower bar here looks like, sevoflurane. And the reason I want you to remember is because this shows the EEG when somebody has what's called a cortical dysplasia. And cortical dysplasia is just a little malformation where the electrodes, where the neurons in the brain don't quite migrate to where they're supposed to during development. And it has this EEG signature. And you can see in channels 4 on the EEG here and channels 8, there's this high frequency sharp activity. And Dr. Palmini from Brazil actually described this and noted that it's basically the fingerprint. It's the electrical fingerprint of cortical dysplasia causing seizures. And in fact, here's a case that you can show where this is present before the surgery. And what Dr. Palmini found is if you still see this high frequency sharp activity in the electrodes after the surgery, the person has almost no chance that you're going to get the seizure stopped. You have to get that electrical signature removed. Okay. And so what would be the problem if you have this electrical signature back with this kind of anesthesia going on the whole brain? Well, the problem is it's just like the lion. You can't see it. It blends in completely. So you can have the anesthesia wipe out the electrical signature, or not wipe it out, it could still be there, but there's no way you could see it because it all blends in. And so our strategy for removing that kind of electrical signature it's called continuous epileptiform discharges, but that's just the name that's given to it, is that we always try to remove it unless it would lead to the person, having something like a paralysis or a loss of language or something. If we can possibly remove it, we definitely do. Whereas other patterns, little patterns that that could possibly be associated with seizures, but usually aren't, we don't necessarily remove them unless they're right next door and don't add any risk to the operation. And patterns where we aren't even sure if it's going to affect the outcome for surgery or not, obviously we don't do anything about those. We just leave them, even if it's something we're not 100% sure why they're there. So I want to just give one quick case study of a person who went through one of these operating room cases. She's a 40-year-old woman who had seizures since she was 4. And the seizures involve fear as her aura. And then she'd stiffen up quickly and fall right to the ground and be incontinent of urine. And she would have 1 to 3 of these seizures every day. So as you can imagine, they had a huge impact on her life. And despite trying many different seizure medicines, nothing ever completely worked. And she was interested in seizure surgery. She came to see us. And we brought her into the epilepsy monitoring unit and recorded seizures. And this is the EEG that we recorded from her scalp, not with electrodes placed inside on top of the brain or anything, just from the scalp. The blue electrodes are on the left, the red electrodes are on the right. And what you can see is that the first changes here, this slow pattern comes all over the left hemisphere, but not in a way that you could really tell exactly where it's coming from. But we got good news when we looked at her MRI. On her MRI, she had a pattern that showed a, quote, lesion that is well associated with epilepsy. And if you kind of look at how all the different little folds of the brain cortex look over here on the right side, and this is the right because the person's lying down like they're coming out of a tube here. So the right is actually over here on your left and the left is over on your right. But you can sort of see the way the normal folds of the brain look over here on the right. And on the left, you can see there's a bunch of little teeny tiny folds right in this segment right here. And that is because the brain didn't quite develop right in this one little area. It developed well enough so that she could completely function normally and everything, but it was just enough of a malformation that there's a lot of little short circuits in this area causing her seizures. And so she came into the operating room for mapping, and we put all the little wire electrodes on top of the brain and found areas A, B, and C here on top of her brain where the little continuous discharges were. So those discharges that we saw that Dr. Palmini described that are so important to remove during seizure surgery. And so she had A, B, and C removed, leaving D, E, F, and all the other things that were perfectly okay. But those areas where the continuous discharges were removed, and all that's left is this little hole, which will fill up with cerebral spinal fluid to cushion everything and not cause any problem at all. And in fact, it didn't cause her any problems at all. We removed all the discharges that were there, but that didn't really matter to her. What mattered to her is that we removed her seizures, and she has been seizure-free in all of the years since surgery. She's so happy at not having seizures that she's been completely unwilling to try tapering her medicine to see if she still needs to take it. She's just darn happy not to be having the seizures. It was so long and she's so used to not driving that she decided that she just didn't want to go forward and get her driver's license. And she wasn't able to go to work. Not working for a long time beforehand definitely changes your ability to seek employment, but her social life improved dramatically and she stopped being injured by her seizures. So to summarize, with intraoperative mapping, it's a great underutilized tool to improve epilepsy surgery, even though it's an old one. It has the potential for lowering the morbidity, reducing costs, and improving surgical outcomes. It requires a big, experienced team, and the best outcomes require knowing in which circumstances you can use it and not use it to get the best outcomes. Thank you. And I realize I used lots of the time up, but I'm happy to take some short questions if anybody has any. And certainly if folks have any questions afterwards, I can put my email address in here. I realize that sometimes things pop into your head later. So if anybody would like, I can just, you can feel free to shoot me an email. Oops, how do I do this?
Okay, I have a question for you.
Okay, sure.
I was messing with my camera. I'm sorry about that, folks.
No problem.
That's still not 100% right, but we'll try and make it better. Okay. Anyway, my wife had epilepsy surgery after 20 years of seizures, and she's 3 years seizure free, which is amazing.
That's great.
And my question is that they told her early on that she had seizure focuses on both sides of the brain.
Mm-hmm.
And my thought was, well, which one is the worst side, you know? And if that side can have the surgery, maybe it would make a huge difference in her life. And it took a while for them to finally catch on to what I was talking about. But and then after they did the SEEG, and they did the WADA test, they were able to kind of say, well, this side might be the side that we would work on, which was her right temporal lobe. And they did the surgery, and then she wasn't seizure free afterwards. But we went to one of these seminars like this, and one of the neurologists, it was a thing, ask a neurologist a question. And so the neurologist, I just basically told him her story in 5 minutes and walked away. And he talked to her for a minute, and he told her, well, you should try a new medication. And so that's what we ended up doing. And the new medication she tried was Briviac. And sure enough, that was the thing that made her seizure free. Now she'd never gone 30 days. And when we first got together in the early days, it was like every other day. And she would have tonic-clonic seizures. So my thing is this, is like, is one side, do you guys now do more surgery on people that have 2 or 3 focal points, or is that still a no-go for surgery? And what's your thought on that?
Yeah, well, we certainly don't do surgery on people where the seizures are all stopped, but because it's just, but we do, but it's a great question. And we have different ways of assessing it now. I think one of the things we can do when seizures come sometimes from one side, sometimes from another place, is we can use a treatment called RNS, or neuropace, where electrodes are placed on each one of the seizure places. And the seizure places can be treated by electrical stimulation. When a seizure starts, the EEG shows it, the device recognizes it and starts electrically stimulating. And that can be very effective at reducing seizures, although it doesn't usually stop all of them. But sometimes what that does is it tells us over time that when the person's on their medicine, they don't have seizures from 2 sides. The medicine takes care of the one side, and on the other side, the seizures are still coming from. That's the side that you can approach by doing a different kind of operation. You can actually do an operation where the seizure focus is removed, and then you can knock out all of the seizures. So there are ways that we can get down to figuring it out in that circumstance. Sometimes it takes a little bit longer because you don't want to do operations on folks if it doesn't have any chance of working. Does that make sense?
Yeah, that makes perfect sense. But my thing is this, is like, if you may not be able to shoot for seizure freedom, but you can maybe shoot for seizure better, you know? And maybe this doing that, I don't know, like I wouldn't even know how to figure it out. But in her case, and she's right here, you can say hello, baby. In her case, it took a while for them to understand that maybe, because they said 2 seizure focuses, you're really not a surgery candidate. And that was the thing. And it was like, well, which side is worse? And maybe that's the one you guys can work on. And it took them 7 or 8 years to figure that out.
Yeah, no, absolutely. And there are a lot of different circumstances where where we kind of try to decide. Like sometimes we see irritability on both sides, but one side is the only side where seizures start. In that situation, we for sure want to do a brain removal surgery and remove the tissue that's causing the seizures. Sometimes there's just super, super rare seizures coming from the better side. And in that situation, it gets a little bit tougher to decide. But I can tell you with this RNS now, it is a much better way of sorting it out, because for one, the RNS treats both sides. So you're already getting treated with something that's likely to help the seizures a lot. And then a side benefit of it is that you might be able to figure out if seizures are really only coming from one side when the person's getting treated with their medicine. Because usually we don't know how it goes when the person's being treated with their medicine, because when they come in for video monitoring in the hospital, we take them off their medicine. So, we could be getting faked out by taking people off their medicine and seeing seizures coming from both sides where they usually wouldn't if the person was taking their medicine. Okay.
Oh, I see.
Yeah. So
Okay.
so that's why that the RNS treatment can also be an RNS long-term EEG that kind of figures it out for you.
Oh, that makes perfect sense. Oh, she does have a VNS in, by the way.
Okay, well,
That
yeah,
worked out.
and if you're seizure free, I wouldn't like.
No, we're not messing with that.
There's only one way to go when you're on top of the world.
No, we're not here.
I'm not messing with my medications because literally I done been on so many medications at once, and they told me my brain that I was having seizures from both hippocampus, and I said, well, I don't got nothing to lose going for 178 seizures a year to where I'm at now.
That's amazing.
She's going to continue to take the medicine too.
I'm taking my medicine no matter what.
It's an amazing story. That's fantastic. Hey, am I going way over my time here? I want to make sure I think because
I think I saw Dr. Clean on the list for 12:30, but he's not in the participants, so I'm not sure if that changed.
Okay.
Or if he's having trouble connecting.
All right. Well, it's fine, I think, as long as I'm not hogging somebody else's time here. Any other questions? I should say, why don't I put my email address out there? And I would be happy to do that, except for I don't know how to do it without, oh, here we go. Let me put my email address in the chat so that if people have questions, they can send me an email. It's just first name dot last name at ucsf.edu. So anyone has any questions or thoughts or want to correct me on something or anything else, feel free. Just send me a message and I'll promise I'll take it to heart.